Hi. Good afternoon. Straight up 4 o'clock. Well, actually 4:01 if you want to be precise about it. 4:01 Mountain Time, which means 6 o'clock on the East Coast, 3 o'clock on the West Coast, and well, I guess that means 5 o'clock in the Central Time. And it is only one place that you must be, and that is Fertility with Fink and Friends, live from CNY Fertility in Colorado Springs. We're very happy to have. Look at everybody joining in. I've got Godson 1417, Bootsy, Terry, Miss Webster, Nina. Oh, everybody. Miss Pittman, Grace Tung. Nice to see you, Grace. Alexis Ann. We've got Staley. Hey, Staley, nice to see you. Certainly glad to have everybody with us here. My name is Dr. Randy Fink, and I am the medical director, the clinical director of IVF services here at CNY Fertility in Colorado, and the medical director of the CNY Fertility at the Miami Center of Excellence in South Florida. On the Facebook side, Dr. Jindy. Wow, well, that's a surprise to see. Nice to see you, and greetings from Tampa to Dr. Anedra. Happy to see everybody here. I hope you had a wonderful week. We certainly had a great weekend, and looking forward to a little bit more snow here in Colorado because it is spring in the Rockies, and that means that it is completely unpredictable. But we've got, let's see, Facebook and YouTube right here. We've got a couple of different Instagram feeds. And just glad to have everybody. Hi from Sarasota to C. Cummings. And hopeful 2023, hopeful in 2023, who says, I'm on day 2 of my cycle. What day should I expect to start my medications? And what day should I expect to do my retrieval? And hi to MKid38. Well, that's a good question. So the way things work in IVF is that usually you do your baselines, right? You let us know cycle day 1, and telling us through the portal is usually the best way to do that, because when you call on the phone, it can be very frustrating. If you've called CNY on the phone, you know that to be the case. For sure. You let us know cycle day 1, usually around between day 3 and day 5. We start by doing the your baseline, which would be an ultrasound and some blood tests to show that everything is indeed at baseline, that the hormone levels are all down to where they should start. And usually just after that, we will start your stim medications, usually on or about cycle day 5. So ideally, what we would like to do is that we would like to have 9 days minimum of stimulation. Now, sometimes it doesn't work out that way. Sometimes your ovaries respond very quickly. And when that happens, we can't get 9 days out of it, but a minimum of 9 days has been shown to favorably affect egg quality. So if we can get you 9 days of stim, kind of starting on day 5, that means that your retrieval, usually then we would give you a trigger. The trigger shot tells the ovaries, hey, we're coming for you. We're coming for those eggs. And when we do that, typically 35 hours later is when you will have your retrieval. So hopefully that helps with some timing issue. It means typically around day 15, typically between day 14 and 16 or 17 of the menstrual cycle is when the retrieval will happen. So hopefully that helps you there. I saw a question over here, and that comes from Buddha Bee, which is one of my favorite Instagram handles. Can you talk about adding in letrozole for a retrieval cycle? So letrozole is one option that we can use to help to recruit eggs. We can add letrozole. Typically, we do so using about 5 days or so of letrozole during the stimulation. And what that does is that it decreases your estrogen levels. And when your estrogen level goes down, your brain hears, oh, we need more estrogen. How are we going to get more estrogen? Well, do you remember where estrogen is actually made? Estrogen is made in the follicular, in the granulosa cells in your follicle in the ovary. So in the ovary, when we do the ultrasound and we look and we see that follicle, it's surrounded by some cells, granulosa cells, and that's your estrogen making factory. So the brain tells the ovaries, make more follicles. How does it do that? It does that by a hormone that's called FSH, follicle stimulating hormone. So basically, you make more FSH, which is designed to recruit more follicles. It also decreases your estrogen levels, which may make you feel better. But there's some evidence that letrozole is not helpful in everybody. We tend to be selective about who we give it. I will say that Dr. Kiltz loves to use letrozole and uses it in just about every one of his cycles that he orders. So, of course, there's differing opinions on that, but that's basically the way letrozole works. There's another medication that sometimes gets used in a similar way, and that's called clomiphene or Clomid. Now, at CNY Fertility, we don't use Clomid quite as much. Clomid can have a negative effect on the uterine lining, and so it limits us just a little bit to what can happen once we make your embryos. And you probably know, somebody's saying you can't hear me very well. Well, that's on this Instagram side here. If you can't hear me on the CNY Instagram side, please let me know. Looks like everything should be working here. Let me know if the audio isn't very good over there. We were talking about I don't even remember what we were saying. What were we saying? I think we were talking about we talked about Clomid, what we can do with embryos. So, okay, thank you, Katie. You can hear me, so okay, I appreciate it. I've got some new microphone thing going on here with this, and so we got this nice big mic here, and it's got a couple of smaller mics clipped to it, and so that made me worry. Last week when we did this, we had. One of them just wasn't working at all. So the first, 10 or 12 minutes of my Instagram feed, there was no audio on, so everybody just dropped off. So we were talking about what happens with those embryos. Well, once we make embryos, there are some different things that we can do with them. We can place an embryo back inside of you. When we put an embryo back in, that's called you know what it's called? That's a transfer. So when we transfer an embryo back, we can transfer back an embryo in the same cycle that we did your stimulation, and that's called a fresh transfer. Fresh transfers at CNY are included in the price. But fresh transfers may not always have as high a success rate as a frozen embryo transfer. So if you have enough embryos and the numbers look good, we encourage you to do a fresh transfer because no reason not to. People absolutely get pregnant from fresh transfers every single day. So we encourage it if you can. Sometimes the numbers show us that it doesn't make sense and that it's not the best idea. In that situation, we may tell you, don't do it because it means that the uterus may not be as hospitable to that embryo going in as we would otherwise like. And so in that situation, your body has really gotten into being in egg-making mode. You're absolutely in egg-making mode, and being in egg-making mode sometimes is not compatible with being in pregnancy mode. So in that situation, we can freeze the embryo, which stops them in time. It lets them hang out and wait for you, really, essentially forever. Let your body recover, and then you can come back another cycle and do what's called an FET, or a frozen embryo transfer. As I said, sometimes the numbers will show us that the FET is really a more successful journey just in terms of statistics, and that's because even in the best case scenario, you've been trying to make eggs. So sometimes the body just isn't so ready to be pregnant. But can you do a fresh transfer? 100%. As I said, it's included in the cost. And so if you can do it, go right ahead. We also have the ability to test embryos. And of course, that testing is known as PGT, pre-implantation genetic testing for aneuploidy, PGTA. And we've talked about that before, and I'm sure we'll probably have a question here about PGT. at some point during our broadcast tonight. So let's see what we have here. If we can get to some questions, I've got Haley. Haley was just here a couple of days, maybe was it yesterday or the day before? I'm glad to know that you're feeling better, Haley. She said, thank you for doing a great job on my retrieval. Oh, yesterday, it was yesterday. 10 mature eggs and all 10 fertilized. Oh, my heavens, that is just fantastic news. Very glad to hear that. What else we have? We have Amy Marie here who says, is a pathology report accurate? Mine says 8 to 9 millimeters removed of tubes. Is that typically enough to reverse? So Amy is asking us about doing a tubal reversal. So what happens when you have your tubes tied? What we're really doing is creating a roadblock so that sperm and egg can't meet one another. And when that roadblock is in place, that's what we call permanent sterilization. And there are really two options later on if you decide you'd like to be pregnant. One of those options is to try to reverse the tubal. And in that situation, we can take out the area where the tubes were separated and literally connect them back together. That's called a reanastomosis, a tubal reanastomosis, which means reconnecting the disconnected fallopian tubes. Excuse me. That's one way we can do it, or we just go right to IVF. Going right to IVF is certainly a quicker way. When we reconnect the tubes, well, in theory, that should put you back at baseline with everybody else who would like to try to get pregnant. And so your fertility rate should kind of really return to what would be consistent with your age. The problem is that sometimes there's still some scar tissue in the fallopian tubes. And when there's scar tissue, that can increase the risk for an ectopic pregnancy. And sometimes can result in that tube still not being open. If you have one functioning fallopian tube, it gives you really the same fertility as having two functioning fallopian tubes. So is 8 to 9 millimeters of tube removed? That means about 1 centimeter. And is that enough to be able to reverse? That should be fine, Amy Marie. So hopefully that answers the question. We do tubal reversals in the CNY system. They are all done in our New York office in Syracuse. There is a somewhat of a lengthy wait. At one point, that wait list was a couple of years long. I think it might be about 6 months now. So that's really not too long to wait. And for the price of what we're able to offer, it makes it very affordable. You can probably walk in someplace tomorrow and get a tubal reversal performed at a cash pay price of close to $20,000. It is significantly less at CNY, and that's why that wait list may just be worth it. And Amy says she has her consultation on Thursday, had some basic testing done. TSH, the thyroid, was at 2.69. And what does that mean to me? Well, the thyroid gland sits here in our neck. If we want to feel the thyroid gland, it's here on the side. We've got cartilage here in the middle. So usually you feel right here, and we would have the patient swallow. And when you swallow, you can literally feel the gland moving against your fingers. In the fertility world, we like that thyroid hormone level, that TSH, to be between a 0.5 and a 2.5. Now, the way the thyroid works is that the higher the number, the slower the thyroid. And the lower the number, the higher functioning is the thyroid. So someone who has a TSH of, pick a number, let's say 8, that person is clinically hypothyroid. And that means the thyroid is not working the way it's supposed to be. Well, when your TSH is 2.7, as it was in your case, Amy, or sometimes we check it and it's a 3.5, for instance, that doesn't mean that you have thyroid disease or that you are overtly hypothyroid. But what it means is that we want to turn the volume knob up. on your thyroid gland in order to get it to function better. And when it functions better, our fertility is improved. Our IVF outcomes are improved. Our IUI outcomes are improved. Our ongoing pregnancy rates are improved. Miscarriage rates go down. So there's everything good about making that TSH between a 0.5 and a 2.5. And if you were at a 2.7, it means that we would give you just the lowest dose of some thyroid to help get that back into the range that we're looking for. So glad to have everybody with us here. I see as I've been talking, I'm getting all kinds of questions, and I'm going to do my very best to try to get to everything that we can here, but forgive me if I don't get to yours. If you want to put the question in again, I will do my best to get it. But so I'm going to go back on the Facebook side here, and what I saw, the very first question, this came in a while ago. Hi to Nina Hair Braiding. That's a good name. How much is IVF? Nina wants to know. Well, at CNY Fertility, I will tell you that that as one of the fertility doctors, we the providers really rarely get into the cost structure of the IVF because it has nothing to do with us. We do the medical part of it. We try to think about things to make them as affordable as possible for you. But if you'll take a look at our website, it's got all the details on the IVF costs, an approximation on the costs of medications. I am told that CNY has just entered into an agreement with one of the fertility pharmacies to be able to package price both IVF and medications together. I am not so sure how exactly that's going to work, but I am told that that information will be released to the public next Monday. So keep your eyes on the CNY social media for that, and hopefully that will make prices even more affordable at CNY. Looks like, oh, there we go. Almost lost a connection there on my Instagram. So sorry about that. Hopefully that's going to make prices even more affordable at CNY. But for now, you can take a look at our at the website at the cost estimator, and that will tell you the exact price of the IVF now. And I will tell you that one of the beautiful things about CNY Fertility is that all the pricing is upfront. There are no hidden fees. There are no costs that show up months and months later that you get billed for. You will know what all your costs are ahead of time. We don't control the pharmacy pricing, the cost of those meds, but if we have a package price, as I understand, will be released on Monday, that can really tell you ahead of time what your medications will cost. So that is a great boon ahead. 5 o'clock in Oklahoma, making dinner, and I hope you have a good dinner in Oklahoma tonight. By the way, our thoughts go out to all our friends in the Midwest and working their way up towards the Northeast, who have been hit with all the weather, the storms, the tornadoes. I fear that we all may know somebody or know someone who knows someone who the tornadoes affected. So our thoughts and prayers go out to all of those who are worried, not so much about adding to their family, but just about having a roof over their heads tonight. Our prayers are with you. Hi, CB Victoria. Hi to NY Cali. Hi from California. Let's see. We've got... is it normal that after a retrieval you feel so tired and sleepy? This comes from Waleska. And for how long can this happen? And why? I had my retrieval in March. Well, so here we are, headed towards the end of April. Should you still be feeling fatigued from your retrieval that you had 4 to 6 weeks ago? And I would say the answer to that, Waleska, is probably not so much. It makes me wonder about your thyroid. Did something happen there with your thyroid where the levels got changed such that now you're feeling a little sluggish? But from a hormone standpoint, your hormones really now should be entirely back to normal, back to where they are. So I would certainly want to look for other reasons why you're feeling sluggish. Like, is your blood count normal now? What's your thyroid? What are your iron stores? And these are things that can usually easily be checked with a blood test. Let's see, we'll go back over to my Facebook side. Um, Amber Roberson had a retrieval this morning. I hope you are feeling well this afternoon. I usually tell people, you know what, you're going to go home, you're going to take a nap, and by evening time, I hope you're ready to go out to dinner because if you're traveling to see us, we want you to make an adventure out of the whole thing and see some new sights, try out some new restaurants. Hi to Alexis, my wonderful nurse practitioner in Miami. Glad to have you with us today. Um, let's see. I had my transfer yesterday. The nurse called and said my progesterone was a little low and they upped my progesterone. Should I be worried about implantation? The answer to that is no. So when we do a frozen embryo transfer, we know that we have to give you the progesterone medication that you need because in a medicated cycle, your body is not making that progesterone itself. So what do? We use the progesterone in oil. It is our least favorite portion of the entire IVF process because it is a shot in your butt that you will have to continue through about 10 weeks of pregnancy. The placenta itself takes over making that progesterone at about 9 weeks. So we give it a little bit of overlap just so that as an extra little margin of safety. But that margin of safety is an important consideration because really the progesterone level you need is probably above about an 8 or a 10. There are some practices that will use the number 10. As long as your progesterone is above a 10, it's fine. We double that. At CNY, we like that progesterone level to be above a 20 in that medicated cycle at the time of your midways because, or even at the time of just after your transfer, because we like that margin of safety. So if it was a little bit low, I would say no, that's not going to have any adverse effect on implantation or the embryo growing. So good luck with that. My Ellie says, I got my PGT test results. 10 of my embryos out of 10 are all normal. Holy cow, are you kidding me? That is a 100% euploid rate, virtually unheard of. So I would say God is smiling on you, my friend. That is really fabulous. When we test an embryo, and we see that an embryo is chromosomally normal, we know that that embryo gives us about a 60% chance of a pregnancy and just above about a 50% chance of an ongoing pregnancy. So those are the best kind of numbers we could hope for in IVF, and congratulations, because wow, that's incredible, incredible, incredible results. On to the Facebook side here. Victoria asks, hi, Victoria, nice to see you. Victoria Olson says, is an AMH of 2.09 good for a 22-year-old? Well, what I would tell you is that that number, the AMH, is, of course, what we call the anti-Mullerian hormone, and it is a measure of ovarian reserve. It doesn't tell us anything about egg quality. It just sort of tells us a qualitative measurement of how many eggs might be left in the ovaries. We are born with all the eggs that we'll ever have. Throughout our life, we lose those eggs until they are all gone. And when the eggs are all gone, that's menopause. Well, that number is probably a little bit low for your age at 22, but it is still a good number. So I would be satisfied with that number. And depending on what you're doing, if you're trying to get pregnant at home, I would say that that is a very reasonable number. And certainly for us, we use the AMH to sort of help us determine what kind of dosing of the medications do we need to use. And that's kind of where we would go with that. So I'm happy with that number, Victoria, and I hope you will be there as well. Hannah Hostetter on the Facebook side says, how late in a cycle can we do a medicated frozen transfer. This will be our second frozen transfer. The first ended in miscarriage at 7 weeks after finding out our embryo split into twins. And poof, everything gone in a short 2 days, and now on to transfer number two. So one embryo can split into two, two embryos can split into four, and that's one of the reasons that we get very concerned when people want to transfer multiple embryos outside of the ASRM guidelines. And there are a set of guidelines that give us recommendations about how many embryos we would like to transfer to you. And all you have to do is just Google ASRM, that's American Society for Reproductive Medicine, ASRM embryo transfer guidelines, and you can read about what those guidelines are. But that's typically what we try very hard to follow. If we put in two embryos, you can absolutely end up with four. And when we increase the number of embryos inside of you, we increase the risk. So sadly, what happened there, Hannah, is that environment probably just got a little too challenging for those embryos, that there may have been an issue with the embryos or with the environment, because now you've got two embryos that are competing for the same resources. Everybody knows somebody who has twins. They're cute. You can dress them up together. They follow you around. You put them together in the stroller. It's very cute, you know. They grow up together. Maybe they look alike. Maybe they don't. Everybody knows somebody with twins or maybe even triplets. But the fact of the matter is that's not a choice that we would want to make for you in most cases. And that's because when the number of embryos or the number of babies inside goes up, the kinds of complications that happen only increase. So you're asking how late in a cycle can we do a medicated transfer? Well, not 100% sure what you're asking there, but I think what you mean is, you know, the way a frozen embryo transfer cycle happens is that it starts when you get your period. The period begins, you're at baseline, the lining is thin, and then we start some estrogen to thicken up your lining. You can get 6 to 12 days of estrogen because you have some control over when that transfer will take place. The only thing that's fixed there is the amount of progesterone. And the expectation is that we are giving you about 6 days, 6.5 to be precise, 120 hours plus or minus 3 of progesterone. So that's why we do it the way we do it. That's why you get typically 6 days of progesterone and oil shots for your blastocyst. So we usually start that at the beginning of the menstrual cycle because we want the lining to be thin, we want the ovaries to be quiet, and we really wouldn't want to do an FET sort of mid-cycle because then the lining of the uterus is all going to be out of whack. What the brain is telling it in terms of hormone, it's expecting it at a different time of the cycle, whereas your embryo is expecting to implant at a particular time of the cycle that you won't be in. So our thoughts go out to you, Hannah, and I know that we will have better luck next time for sure. Okay, let's see. Francis JP says, good evening from Boston and hello to Boston. Last week, you had an HSG and found out that your right fallopian tube is, and it looks like your right and left are blocked. Do I need surgery? I'm 37 years old to conceive naturally, or do I need IVF? Well, I think, yeah, Francis, looks like there was maybe a little typo in there. I think you're saying that both sides were blocked, your right and your left. So if one side is blocked and one side is open, you can still conceive naturally. And in fact, your fertility is really not so affected by having only one functioning tube. You may have an increased risk of a tubal pregnancy or an ectopic pregnancy, but you can still conceive naturally. If both tubes are blocked, really your best option is IVF at that point. There may be some procedures that can be done to try to open up a fallopian tube, but doing that really becomes high risk because that means the tubes are damaged. And so the odds of ending up with a tubal pregnancy are unfortunately very high. Now, if you are in a place where IVF is going to cost you $35,000, then you're going to say, gosh, I would like to do anything but doing IVF. And that's one of the most common reasons that folks from all over the country come to see us at CNY because of that affordable pricing. There is no reason that you need to spend $35,000 for the very same IVF that you can get at CNY Fertility for in the $4,000 range. It used to be, it was $39.95. The price went up a little bit. As I said before, look on the website. The exact prices are right there. But Francis, I would certainly think IVF is going to be your fastest and most reliable path to pregnancy. Greetings to Boston. What treatments are available? This comes from Faithful and Fruitful. What treatments are available with a very low AMH of 0.1 with Hashimoto's? So Hashimoto's is I love the name, Hashimoto's thyroiditis. Hashimoto's is autoimmune thyroiditis. And what it means is that your body has created an autoimmune response against your own thyroid gland. This is one of the more common reasons that folks will end up having thyroid disease later on in life. So some people with Hashimoto's have no symptoms at all. Some people with Hashimoto's can feel bad because of it. Sometimes the thyroid hormone levels can go both up and down as a result of that Hashimoto's. How do we check for Hashimoto's? We look at what's called the anti-thyroid antibodies, or what's called the TPO, the thyroid peroxidase antibody. It's a simple blood test that shows us whether you have mounted an immune response against your thyroid. And if you have, then that suggests that there is some autoimmune thing going on in your body that may have some effect on your fertility. So what do we do with that? Well, certainly we treat the Hashimoto's. Again, we want that TSH level to be between a 0.5 and a 2.5. There are some places that will treat looking at a hormone level that's called a free T3. I would want the free T3. And in the anti-aging side of things and in the hormone optimization side of things, I would always look at a free T3. And I want that number to be between a 3.5 and a 4.5. So it just depends on which marker you're using. We would want to treat that with one of our immune protocols as well. So we add that immune protocol into just about every patient who is going to undergo IVF because we know that the immune system and inflammation plays such a significant role in fertility issues. That's part one. The other issue there is that low AMH. So when the ovarian reserve level is low, again, what that tells us is that, well, we may have a bit of an uphill battle in order to try to be successful here. And there's a couple of things that I tell people. Excuse me. First, I tell folks, well, I want you to know that this may require more than one cycle of IVF. I think there's a little bit of a misnomer. People who maybe haven't been through the process have an understanding that you go in for IVF, you do one retrieval, you get whatever you're going to need. It makes an embryo, you put that embryo back in, and voila, you're pregnant. Sometimes it works that way. And when it does, that's fantastic. But sometimes it doesn't. In fact, most of the time it doesn't. IVF is a numbers game. It's something that we have to do and work with the numbers here in order to get enough eggs to give you enough embryos in order to give you the kinds of options that you want, right? That's the numbers game. it may require more than one cycle of IVF to get there. There are some particular protocols that we use in folks who have a diminished ovarian reserve. There are some little tricks that we have to try to coax as many eggs as we can get from the ovaries. So, faithful and fruitful, you are not without options, my friend, and I certainly hope that we will be able to help you. Um, does embryo grading truly matter? This comes from Sally Panera, who says, my 3AA blast 2 years ago worked, but not this round with another 3AA. Does embryo grading matter? If you've been with me before, you would have heard me say, no, it's a beauty contest. And that's all it is. And if you've ever if you've ever suffered through watching a beauty contest on TV, you know that this one sings better than that one. This one plays violin. That one plays the piano. This one tap dances. Are any of them any more beautiful than the others? No, not necessarily. So what embryo grading is a system by which it was really developed so that an embryologist could look under the microscope and hopefully be able to tell from looking which of the embryos are normal. Well, it turns out it doesn't work that way. So you can have a whole group of embryos that are graded, and then they're PGT tested to tell us which of them are chromosomally normal. And it may turn out your poorest graded embryo is the only normal one in the batch, while your highest graded embryo has a series of complex chromosomal abnormalities. So we don't go by embryo grade, except if we have untested embryos, we need some criteria to say, well, which embryo are we going to transfer? Well, typically we're just going to kind of take what is the best looking one. But we will, I think, again, we should have an embryologist come and visit with us here on Fink and Friends, because the last time that Tammy Titus was here, one of our senior embryologists in Colorado, she told us every day of the week we see embryos that really don't look so good compared to some of their brethren in the dish, but they are the ones that end up getting you pregnant. So I really would encourage you not to be hung up on a grade of an embryo or how that embryo looks, or to think that it doesn't have the possibility of getting you pregnant. So Sally, best of luck to you on your journey there, my friend. M-Kid wants to know, is priming needed, or can you go straight in to stims? You can go straight into IVF stimulation without priming. I do recommend that you do some, there are some situations where we really want to aggressively prime people, particularly those who have a lower ovarian reserve and who we think may have an issue with egg quality. And there's some different things that we can do for priming. I have come to the belief that the very best thing that any one of us going through the process can do for priming is to use the supplements that are evidence-based to affect the quality of our eggs. So the book that we've read is called It Starts with the Egg. It was written by a woman with the last name of Fett, F-E-T-T. It's a pretty easy book to read, but we've read it for you. You don't have to read it. We plucked out all of the evidence-based recommendations, basically every study that's been done on all the different supplements, and pulled out those recommendations and put them on a list for you, which I am happy to send to you. You can Instagram me at Randy Fink MD, and I am happy to send you that list. You can also Instagram our nurse practitioner here in Colorado Springs, Brandis Montez, and she is Brandis Courtney, BRANDIS COURTNEY, whereas my handle, Dr. is Randy Fink MD. That's a little easier to spell. And we will be happy to send you that list of the evidence-based supplements. And that's really, I think, the best thing anybody can do to try to prime before doing IVF, because we can really make a big difference both in egg quality for folks who don't have ovarian reserve issues. There's a special list for people with ovarian reserve issues. There's a special list for folks doing embryo transfer. There's a special list for sperm quality. So please take a look at that, or read the book if you'd like. because it's really packed full of some very useful information. Tiffany Clark on the Facebook side. Hi, Tiffany. How much does dieting with keto or carnivore affect the IVF process? Well, if you ask Dr. Kiltz, let's just clarify some terms there. Keto means it's high fat, moderate protein, and low carb. What's the principle behind that? The principle is that carbs are pro inflammatory. So, more carbs, more inflammation, less fertility. Whereas the high fat in the meat is, or in the diet, I should say, the high fat is anti inflammatory. So, in general, keto is the diet that we recommend for those who are trying to get pregnant. If you listen to any of Dr. Kiltz's work, you'll know that he takes that to the next step, and that is carnivore. And that is really basically, for lack of a simpler explanation, meat only. Um, Beef, butter, eggs, the baby diet is what that's called. And take a look at the CNY Facebook or at his Instagram site, and you can hear him talk ad nauseum about carnivore. And if you were interested in that, please call him on the phone. He is a wealth of knowledge when it comes to it. So Dr. Kiltz believes that carnivore is very important, and we certainly feel that keto does make a difference in fertility. Let's see what we have. Hi, Laura Ramirez, and hi to my friend Miss Santiago. Nice to see you both here today. Erica says, I had my tubes tied and then untied and looking to go towards you guys. Not sure what you're asking there. I had my tubes tied and then untied and looking to go towards you guys. Is this a good option for me? Well, not sure what you're asking there, Erica, but if you had your tubal reversed and it's working for you, by all means, get pregnant. And if you're having difficulty, then we can certainly help. And if you're thinking about having your tubes untied or a tubal reversal, we're happy to consult with you about the pros and cons of those things. Gabby Thorpe, good evening, my friend. How can I increase egg quality leading up to retrieval? Well, gosh, that really goes back to those supplements. And I think that that's probably the best thing that we can do to improve egg quality. There probably are some other things. We also commonly use growth hormone, human growth hormone, which is called Omnitrope. Omnitrope is a medication. It's a daily injection that you give to yourself. That really is what growth hormone is, what keeps us young. So as we mature, we're going to go with that word. As we mature, and our DNA starts to become less stable and things start to change, our growth hormone levels are going down over time. So the thinking is that if we can maintain our growth hormone levels, then we may be able to stay younger. And so certainly folks who use growth hormone in the anti-aging and hormone optimization world can tell you it does good things for you. It increases sex drive. It's fat reduction and muscle building. It's hair and skin and nails and all kinds of things that are good. From a fertility standpoint, it may have the ability to potentially even help us correct some of the age-damaged DNA at the level of the ovaries. So when we medically are priming you, we'll typically use growth hormone, Omnitrope. We also think about low-dose naltrexone, which is basically functions as an anti-inflammatory and as an immune system booster. Sometimes we'll use some estrogen because estrogen and progesterone are the language that the ovaries speak. So the supplements and the priming ritual are really kind of the best things that we can do, Gabby, in order to improve egg quality. And that's something that is a very worthwhile consult with us if you're thinking about doing another cycle and you're concerned about the function or concerned about the egg quality. Talk to us because we can really give you some good recommendations about how we can improve that. And that's why I always tell people I am much more concerned with egg quality over egg quantity. I don't need you to have 30 eggs in order to get you a baby. What I would like is I'd be happy with 3 eggs if those 3 eggs are good normal eggs. They give you good normal embryos. They give you good normal babies. 3 eggs would be fine. We don't need all 30. So egg quality is a very, very important piece of the puzzle. One other thing I want to mention because we are using it more and more. I'm seeing it in more and more protocols now, and that is a drug that's called metformin. Many of you have some experience with metformin because it's memorable when you take it. It has some side effects. Let's just say it has some crappy side effects. It causes some GI problems, and so if you start on it too high and too fast, you'll spend some time in the bathroom. It can make you bloated. It can make you gassy. It can give you diarrhea. And it's kind of an interesting mechanism the way it actually does that, but there are some ways around that. So metformin, and we'll talk about that in a second. Metformin is a medication that's used to treat people with type 2 diabetes. So in the diabetes world, that's what it does. In folks with polycystic ovaries, we can often use it because it helps with insulin resistance and it helps the ovaries function more normally. But in the IVF world, it has a very significant effect on egg quality. And again, egg quality, big important piece of the puzzle. And Gabby, that may be another thing that we can do in your priming. So even folks who aren't polycystic, don't have polycystic ovaries, or folks who aren't diabetic, we will use metformin sometimes to improve the egg quality. What else does it do for you? Well, it can decrease the miscarriage rate and it decreases the risk of certain pregnancy complications, specifically gestational diabetes, once you do get pregnant. So metformin may be an important piece of the puzzle for those of you looking at egg quality issues. The way I would do it, the way I like to do it, is I use the extended release version of metformin. So it's taken once a day and it's taken at night before bed. That can minimize those GI kind of side effects. I usually start with 1 pill and take 1 pill at bedtime for 10 days. And then after 10 days, I like to increase it to 2 pills, which is usually going to be the therapeutic dose. Now, some people don't tolerate 2 pills, in which case 1 is better than nothing. So that's okay. But if we can do it that way, I do. Again, it minimizes some of the GI side effects and really can help a lot with egg quality. So if metformin comes across your table, you'll know that's really the reason why. There is a supplement, pardon me, that we recommend for folks with polycystic ovarian syndrome, and that is called myo-inositol or inositol, kind of the same thing. They really do the same thing, myo-inositol and metformin, but some people prefer to take a supplement. What's the advantage of taking the supplement? Well, many people say, well, it's natural, so it must be better for me. Okay, if that's your choice, then certainly myo-inositol is a good thing for egg quality and for polycystic ovaries. In my opinion, metformin is pharmaceutically manufactured, so we know what's in every pill. We know it's going to be the same dose in every pill, that there's going to be consistency across the bottles, and you can't always say the same thing about a nutraceutical or about a vitamin. The other thing is, even if you don't have insurance, metformin is dirt cheap. If you do have insurance, figure it's, $10 for a month's supply of metformin from the retail pharmacy, whereas the supplement is probably going to cost you $25. So the supplement's going to be more expensive. and certainly doesn't work any better. And just because people say it's natural doesn't necessarily mean it's a better thing. So give that some consideration. Let's see, I've got Nanushet. Hi. Dr. Fink, after 4 failed transfers of high grade donor egg embryos, I was told my sugar was high, and I'm currently on Ozempic and wanted to know what is a safe zone to be in and how long afterwards will I have to stop the Ozempic? So, good question there. If your hemoglobin A1C, that's really the best test for your blood sugar on a longer term basis, because I can eat a Milky Way and check my blood sugar and it may be 200. I was going to check my blood the other day, and I had a I had a latte that I got from the coffee place, not thinking that it was a caramel latte, and that alone was probably enough to make my blood sugar look like I was about to go into a diabetic coma. So it was pointed out to me, probably not the best time to check your blood. And I'm like, you're right. I didn't even think about it. And I'm like, it's just coffee. How bad can it be? Well, so the A1C is also called glycosylated hemoglobin. And what it's telling us is basically what has your blood sugar been over the last 90 days. So we want that A1C to be less than a 5.7. So if it's a 5.6 or below, that's considered normal. If it's between a 5.7 and a 6.4, that's considered pre-diabetes. And if it's above a 6.5, that's considered overt diabetes. And that's one way to make that diagnosis of particularly type 2 or adult onset diabetes. So I would really like to see your A1C at a 5.6 or less. Ozempic, Wegovy, these are medicines. This is called semaglutide, and this is an excellent medication that we are using very commonly for weight loss as well. We also know that losing some weight is probably very effective at improving fertility, how much weight to lose. And you might ask yourself the same question. Usually we'd say about 10% of your body weight is enough to make a pretty big difference in the way you process your hormones. Now, the problem is semaglutide is not well studied in pregnancy. Is it safe in pregnancy? Well, I have my opinion on that, but the FDA says it's not studied, and so you shouldn't do it, that the risks outweigh the benefits. And that semaglutide can actually last in your body for a couple of months. In general, I would say I like you to stop your Ozempic or your Wegovy, your semaglutide, about a month before you intend to start to be pregnant. So you can use it during IVF if you're just retrieving eggs, but I certainly would want you off of it by the time you do an embryo transfer, unless the FDA gives us some different guidance at some point in the future. And because it's such a popular and commonly used drug now, it's a very excellent drug. I suspect there will be more experience with it as it pertains to pregnancy. And so we will see some changes coming down the pike in those recommendations. Well, it's about 6 minutes till the top of the hour, and you're on Fertility with Fink Friends live via internet from Colorado Springs. We've got about 4 or 5 minutes left, so let's see if we can get to some more questions here. I have PCOS and couldn't do a fresh transfer. Could letrozole be added in to maybe lower the estrogen for a potential fresh transfer? Well, I will tell you what happens there. Yes, it's true. Letrozole will lower your estradiol level because that's how it works. But it's not changing the fundamental chemistry of what's going on and your body being in what I call the egg-making mode. So folks with polycystic ovarian syndrome have a tendency to become a little hyper-stimulated. And what we're doing here for IVF is called controlled ovarian hyperstimulation. So we do want to get your ovaries all revved up, but if they're a little too revved up, it can make you quite sick. And one of the risks is that then if you get pregnant on top of it, that can make you considerably sicker. The other thing is that in the face of ovarian hyperstimulation or the risk of hyperstimulation syndrome, we run the risk that the uterus is just simply not hospitable to that embryo. So even if we lower the estrogen level, we're not changing the fundamental problem on the inside that you did a great job of making eggs. But maybe that means you're not ideally suited to being pregnant right at that moment. So hopefully that answers the question. Let's see here. It comes from Hopeful in 2023. We answered there before. About a 13-hour drive from Colorado Springs back home. How long should I rest after my transfer before making the trip? To be honest with you, a lot of folks come in, they have a transfer, and they head back home. We like you to take it easy for a couple of days after doing transfer. But riding in the car, keeping yourself hydrated, stopping for gas and to go to the bathroom, I'd say that's probably pretty restful. I wouldn't recommend that you be the driver there, but if you want to head back home after transfer, I do think that that's okay. Lauren on the Facebook side says, hi, Lauren, I am on Lovenox 30 milligrams twice daily after a successful transfer, and my platelet count came back slightly elevated. What would be a concerningly high platelet count for me to monitor for? So platelets shouldn't really, don't really have too much of an effect there as it pertains to the Lovenox. Platelets are what your blood makes to cause your blood to clot. Lovenox is something that we use to thin your blood and to make it not clot. Platelets are something that we call an acute phase reactant. And so sometimes after the stress of a retrieval or of some physical illness or some physical stressor, you will see your platelets start to go up. I would certainly say a platelet count that's above yours, you said were 414. Anything that's, I would say, above about 550 would be cause for me to say, now, what's going on there? Again, usually it is an acute phase reactant and not something to be overly concerned about, but that's when I would give myself a double take on that. Let's see what we've got here. I think we probably have room for maybe one more. Since letrozole lowers estrogen and can affect the lining for an FET during a natural modified transfer, can one add estrogen after, or is Viagra better for lining help? Well, so if you're doing a natural cycle FET and you have regular periods, I would advise that you don't use letrozole. Letrozole does lower the estrogen level, but typically is not thought to have a direct effect on the uterine lining. So given that, we usually say it's fine to do. Clomid, on the other hand, does have an effect on the uterine lining. So we don't like that as much. So we still check estrogen levels, and at CNY, they will still supplement your estrogen if they find the level is lower than where they want it to be, even on a natural cycle, which isn't strictly necessary, but yet it's something that we do to kind of keep the peace in the world. The most important feature with the uterine lining in a natural cycle is going to be the thickness of the uterine lining, or what we call the endometrial stripe. And that's something that we measure by ultrasound. Looks like we are going to start to run out of time. One quick other thing, this goes to Naomi on Facebook. Any thoughts on transferring more than one embryo with a bicornuate uterus? The bicornuate uterus increases some risk for preterm labor and for malpresentation at the time of delivery. So I would be very judicious about that, because having twins is already an increased risk for preterm labor. So I'd want you to be very careful with that, Naomi. Looks like we're going to run out of time here. I would like to say it's been such a pleasure to be with you like every Tuesday, and I hope you'll join me next week for Fertility with Fink and Friends from Colorado Springs. Until then, remember that fertility is not your definition. Infertility is not your definition. It is merely one mark in the book, and we are here to help you write a new chapter. God bless you all. Thanks for being here, and we'll see you next week.